Hi, and welcome to the Dr. Coffee Podcast, your weekly blend of motivation, encouragement, education, and insight into all things medicine for junior doctors and medical students in South Africa. By now, you know that my name is Simon Fraser, and I'm a second-year intern doctor at Maxeke, Johannesburg Academic Hospital. I started the Dr. Coffee Podcast last year to broaden my knowledge and understanding of the incredible world of medicine and surgery and the variety of subspecialties and disciplines that exist within them. Each week's episode features an interview with the consultant or senior registrar in a specialty requested by the Dr. Coffee audience, or a topical episode that's applicable and helpful to our audience of junior doctors and medical students. You're invited to learn and grow with me as I discover the perks, pitfalls, and perils of specializing and practicing medicine in our beautiful country. Before we dive into this episode, as promised back in episode 23, I'm pleased to make a special introduction to a new member of the Dr. Coffee podcast team. I first met her when she was an intern doctor and I was a final year student in pediatrics. She graduated from UFS in 2020 and she's currently a ComServe doctor in the province of Limpopo. With a flair for humor, a knack for social media, and imminently cooler than me, I'm sure you're going to love what she brings to the podcast. She's none other than Dr. Knox Mpambukeli, and she'll be managing the social media accounts of the Dr. Coffee podcast, as well as generating new content to bless your feed. You can follow her on Instagram and TikTok with the username @Knox_Kelly, that's Keli. Welcome, Knox, and it's awesome to have you on board. Knox has already been busy and has started our new social media pages on Facebook and TikTok. In addition to Instagram and YouTube, you can now find us on Facebook at Dr. Coffee, that's Dr. Coffee, all one word, and on TikTok at Dr. Coffee Podcast, also all one word. I'm not sure why we had to add the word podcast to the TikTok handle, but probably because there's some other less likable character going by the name of Dr. Coffee in the TikTok userverse somewhere. And now to this week's special guest. In this week's Coffee with Consultants feature, I interviewed Dr. Alicia Porter from the Child and Family Unit in the Department of Psychiatry at the Maxeke, Johannesburg Academic Hospital. Dr. Alicia Porter completed her undergraduate training at the University of KwaZulu-Natal Medical School in 2002 and completed her internship at Victoria Hospital in Cape Town and her community service year at Edendale Hospital in Pietermaritzburg. She then worked in the UK for a year before returning to take up a registrar post and complete her specialization in psychiatry at the UKZN. After this, she took up a post as a forensic psychiatrist for a while before working in private practice for 6 years in Durban. She then decided to move up country to Johannesburg to study further and subspecialize in child and adolescent psychiatry. Dr. Porter is passionate about all things mental health. She's a mental health advocate and also one of the founding members of the Health Workers Care Network that was established as a mental health support and training network during the COVID-19 pandemic. Because of this, the mental health of junior doctors and medical students became an important topic during our conversation. Now, usually I make reference to the show notes at the end of an episode, where you would usually find links to articles, resources, or references pertaining to each guest feature. But due to the nature of today's discussion, I'd like to draw your attention to them now before the start of the interview. On whichever platform you're listening to the Dr. Coffee podcast, whether that be Apple Podcasts, Google Podcasts, Spotify, or YouTube, the show notes should be easy to access while listening to this episode. This is important. If you can relate to or identify with any of the symptoms or signs of depression, anxiety, or other mental states mentioned in today's podcast, if you're feeling lonely, anxious, or overwhelmed, if you're concerned about your own mental health in any way and want to reach out for help, you'll find a number of helpful resources with links and phone numbers to call right there in the show notes for this episode. The podcast's email address is also available. That's drcoffeeza@gmail.com. Please, coffee beans, let's encourage and support one another. If you're battling with something, know that an injury to one is an injury to all, and the Dr. Coffee podcast team and listeners stand with you. With that said, and without any further ado, please welcome Dr. Alicia Porter. Welcome to the Dr. Coffee podcast, Dr. Alicia Porter.
Hi, Dr. Coffee. I'm really excited to be here this morning and talk all things psychiatry.
Wonderful. We're really looking forward to hearing what you have to say. The first question which we ask all of our guests on the podcast is about your junior doctor years and your medical training. So where did you go to medical school? And then following that, where you did your internship and community service?
So I am a Durbanite born and bred. So I studied at the University of KwaZulu-Natal. And during my training, the medical school then changed its name to the Nelson Mandela School of Medicine. So I did my undergraduate training in Natal. And at the time when I qualified, we only needed to do a year of internship and a year of community service. It was always my plan to do internship outside of the province. So I went off to Cape Town. It did feel like it was in another country, and I did my internship at Victoria Hospital in the Cape. And it was then marriage that brought me back to KwaZulu-Natal, where I did my comm service at Edendale Hospital in Pietermaritzburg. And I spent most of my year in comm service doing surgery.
Oh, wow. So tell us about your internship experience, first of all. Was Victoria a pleasant hospital? Was it your first choice for internship?
So back in the day, it was a lot easier because Victoria Hospital, to answer your question, was my first choice. But we were a lot more collaborative in those days, where as a class, we sort of decided amongst ourselves before the applications went in. And it definitely wasn't as difficult as it is now. Wow. I mean, I can remember when my dad was convincing me to do medicine, he said, "You'll never be without a job." That's not so true anymore, but it was very true then. So I got my first choice, and I chose the hospital because it was a small hospital. It was a very steep learning curve, but I wanted a small hospital because I wanted to be hands-on and learn stuff. So it was a really good environment to do that. And we came from all parts of the country. So we then were like a little family because there were a few of us as interns.
Awesome. There. Now, the Pietermaritzburg circuit, which I believe Edendale is part of the Pietermaritzburg circuit, it's quite famous for its social side as well. So your community service, was that an enjoyable experience, and did you get to have some social life during your ComServe year?
Yes, it was. I mean, even in my internship year, because I think that was one of the things that got me through my internship, was connecting with my fellow interns and creating a sense of support for each other, because like I said, we came from all over. And even within comm service, although I was now back home, it really was a small, very vibrant town with a lot of connection and support. Although, with Edendale, it is quite like the wild, wild west. But even in that, the camaraderie, the support was really something to, it was something to remember. It's the thing that I remember most about my comm service. Yeah.
Wow. So you did the year, was the whole year spent in surgery, or was that just one part of your community service?
So technically I should have moved where you needed to do like
6 months and
6 months and 6 months. But because I enjoyed surgery so much, one of the other comm services wanted to swap out. And so with special permission, they allowed me to swap. And at that point, I thought that, because I actually worked with a female registrar, and we were one of the few females within the department. Well, she was the only female registrar.
Oh, wow.
And I worked under her. And so I really at that point thought maybe surgery is something that I'd want to consider. So much so that I actually stayed on another 3 or 4 months after finishing my comm service before sanity prevailed. Essentially, when I got to medical school, I thought that from the beginning I had wanted to do psychiatry.
Okay.
So when this love for surgery sort of was born, I almost felt like I was cheating on psychiatry.
Oh, wow.
And so I then took a break
Yes.
after that to kind of think about what I wanted to do. And so
Yes.
I then went to the UK
Oh, wow.
for about a year to kind of think about, is it surgery? Is it psychiatry? Obviously, the thought process was quite different because, again, at that stage, there were very few females in surgery. And, some of the questions I asked myself, as a female, I had to think about, quality of life. I had to think about, whether I was thinking of having a family and what that would look like, because surgery is quite a demanding, specialty. And, the reality is, as females, we do need to think about those kinds of things. Also, the idea that it was quite a male-dominated field and having to kind of go to work every day and prove myself was something that I thought about, in that regard. And then my first love was psychiatry.
Yeah.
But
it does sound like you went through a journey where you scratched the surgery itch, you examined surgery and said, is this something that I want to do? And so you made that decision with some experience, weighing up options. That's what it sounds like.
Yes, because I think that oftentimes we sort of feel like we have to make a decision and we have to make it like now, when actually we might not need to make the decision and make it now. We can actually think about it as long as, your logbooks are done, they're submitted. I know some family friends who actually, after they did internship, comm service, decided like, I don't even want to do medicine anymore. But
wow.
Here they are back again. So it's not linear.
Yes.
It's very dynamic, and we're allowed to take time. But I do think that we kind of program to, like, I need to make a decision and I need to make it right now. Whereas if we maybe just took the time, we have time.
Correct.
I think that when you make a decision, it should be a decision that, if you've thought about it, it is more sustainable in the long run.
There does exist a hierarchy in medicine, and there is what's laid out for people, what does look like a linear path. What do you think contributes to the pressure people feel to conform to that linear path?
I think that there are multiple factors, because I think that as individuals, if I think about like my class at med school, unfortunately, it is the part of the population who are the overachievers. So, you come in because you have to obtain a, maximum.
An excellent matric,
Excellent matric. So, the kind of person who chooses medicine, obviously this is a generalization, but for the most part, it's the anxious, overachiever, high functioning, for the most part, and smart. And so because there's such a high demand when it comes to medicine, and it's highly competitive, I'm not even sure, like I can remember almost 60% of my class saying medicine was not their first choice. They wanted to do actuarial science in Cape Town, for example, but because of family pressure,
sure.
And I think there is a cultural aspect to that, because if I think about it, I wanted to do law and my marks were sort of good enough to get into medicine, and my dad was like, don't you just want to try medicine? I didn't even do biology at school, because
sure.
medicine was not really something that I wanted to do. I wanted to be a lawyer. That even when I meet my teachers from school, they're like, what? Did you not do? I was like, no, actually, I did medicine. not that I regret the decision, because I think maybe my dad knew me better than I knew myself at the time. But again, it was also quite a, from a cultural point of view, it was quite a, my daughter's doing medicine as opposed to my daughter's doing law. Both honorable career choices, but we have to sort of admit that there is that,
100%.
where doing medicine is perceived as, and it really is just a perception.
Sure.
Because I don't think that the general public actually know the struggle and the difficulty. But I digress now from your question.
So let's come back to psychiatry as a whole. You have a definition of psychiatry for us. So let's start with that. Start with what psychiatry is, and then we can talk about the journey to becoming a psychiatrist.
Okay, so what psychiatry is the study. It's actually a medical specialty. Mm-hmm. So it's a study of conditions that cause mental illness. So it's the assessment, the diagnosis, and the treatment of mental illness. That's the Oxford Dictionary definition. Mm-hmm. But what psychiatry really is, or what it feels like for the most part, it does feel like a stepchild of medicine. There's this perception out there that psychiatrists are not real doctors.
When you say the perception out there, do you mean with the public?
No.
Or within medical practitioners?
With my fellow colleagues.
Okay.
I've often had to have really
strong
robust
words.
And strong words with my fellow meds. I sat next to you at med school, so I have a medical degree.
Yes. Wow.
Okay,
we're going to unpack that a little bit, but I think first of all, we also need to say that the number of times that the public confuse psychologists and psychiatrists must be really exhausting for you. So for the benefit of our medical student audience, please just clearly delineate the difference in terms of how you study to be one, because the qualification process is different, and in terms of where you practice.
Okay, so if you were here with us, you would have seen my eyes rolling. That is the truth. So in order to be a psychiatrist, you need to do medicine. It is a medical speciality, okay, which includes a psychotherapy aspect to it, but you have to be a qualified medical doctor in order to do psychiatry, because you would diagnose, you would treat, which means you're able to prescribe medication. A psychologist, on the other hand, which takes equally long, and it is highly competitive, to get into. You would do a basic degree like a Bachelor of Social Science or a Bachelor of Art. You would need to do your honors, and the difficulty then is getting into a master's program.
Okay.
And after your master's program, you would need to do an internship if you are going to be a clinical psychologist. That process takes about 7 or 8 years. But getting into a master's is highly competitive, and a psychologist is not able to prescribe medication. Although we work together, so we are allied, those are the basic differences.
Okay.
But even our colleagues confuse psychology and psychiatry.
Yes.
And even after I say I'm a psychiatrist, they'll say, "What do you do again?" No.
Sure.
Psychiatrist.
So what do you tell the members of the public who get this confusion? Because obviously you can have stronger words with a colleague in the hospital, but if somebody in the public, like let's say you went to your school reunion and they said, "Oh, you're a psychologist," how do you correct them and say, "No, actually, I'm a psychiatrist and this is what I do"?
So, it depends. It does get quite tiring. And so, I try to be as diplomatic as possible. And so I would basically, the same way I've described it now, the explanation I would give to the general public. Because oftentimes people genuinely don't know, and they will ask, what's the difference between psychiatry and psychology? Because I think for the same reasons, they have been sort of mixed up and lumped together.
Look, it's more important than just mere semantics, right? It's not just about having the correct title and the correct scope. It's because you want to ensure that your patients get the right care, and you want to refer on adequately, right? So there's some things that a psychologist will be very effective at managing and treating, but you have a certain scope and you are the expert at treating those specific conditions and those diseases. So what is the path like? Let's say somebody says, "I want to become a psychiatrist." What's the path like to specializing in psychiatry?
So, currently it is quite competitive, and it is taking a lot longer, in the sense that, and it depends on where you choose to specialize, because within the provinces, they have different, the different universities have different, criteria. But I mean, the one thing I would say is that you definitely need a passion. It's not this seems like a nice quality of life that you may have, so let me try this. I do think that you need to have a passion, because it does get rough. Because unlike any other discipline, the stigma around psychiatry is something that we still need to figure out how we're going to break. So, it's almost like I said to you, it's a stepchild of medicine. Yeah. So you kind of enrolling for quite an uphill battle, not just in terms of what you need to do, but even just interacting with interacting with the medical fraternity as a whole gets quite difficult. So here at WITS, you would need to apply for a medical officer post, and that's usually a 6-month or a year post. And then you would make an application to the registrar program.
Are there any primaries to write for psychiatry?
Yes, there are primaries. We also have a diploma in mental health. There are primaries, and then the registrar program. But we have seen a significant increase in the last year or two in terms of applications. So it is oversubscribed, and there are always more candidates than there are posts that are available. I mean, that's just systemically. It wasn't always that way, but it has become more popular, because I do think that there has been an increased awareness. And in terms of quality of life, particularly, as a female, it might be quite an attractive speciality to consider.
Sure. So what is the average amount or period of medical officer time that somebody is typically doing before that registrar post becomes available to them? Are people doing just the 1 year? Or are they doing 2 or 3 years? And is there anything that a junior doctor can do to make their application more appealing? Should they have publications? Should they do research? Should they have primaries and the diploma?
So, I mean, that's quite difficult, because at the moment, it's quite individual. There are some people who are in the program for 6 months. There are some people who are in the program for 18 months, some even up to 2 years. And I always say that once you are shortlisted, for example, for an interview, that interview is what you need to prepare for, because that is what is the thing that is the decider. So like things like research, things like having a diploma in mental health, those are things that will be useful to make a shortlist, for example. But that doesn't guarantee you. It's how you perform in that interview and how you're going to convince that panel that you want this, that you want to do psychiatry. That does play a part. So, that's the thing that we're not taught at medical school, like how to interview, how to conduct yourself in an interview. What are the things that you need to do? And so those are the skills that you need to practice.
I can think of nothing more stressful than being interviewed by a panel of psychiatrists because they're going to ask you questions and be just observing so much about your demeanor, your body language, the way that you answer.
Yes, and I mean, I think that would be for all specialities, really. But I don't think that we pay enough attention to the fact that it is an interview process. For example, if you went for a job in corporate, you need to sell yourself. But as medical professionals, that part of us is just
underdeveloped.
It's very underdeveloped. I mean, a viva or an oral is not actually, the same as an interview where you have to sell yourself. And that, I think, is where the missing link is, where we don't get enough practice in the fact that I'm actually going for a job interview.
Yes.
In corporate, they have recruiters where they, take them through, mock question. That's quite important because that's, what gets you the job. All of those other things may get you onto a shortlist for consideration. Yeah. But my advice would be maybe we need to think about the job interview process, because it's becoming more and more competitive. It's not just, okay, we have 5 people and we have 5 posts, therefore, it is more competitive.
So this is your opportunity. You said that psychiatry is very popular. It's oversubscribed. There's more applications than posts available. This is your opportunity to sell psychiatry so that a future psychiatrist listening to this interview is going to say, wow, there is no ways I'm doing anything but psychiatry. What is the best part? What are some of the pros and the benefits of doing psychiatry that really appeal to you? You mentioned that it was one of your first loves in medicine. So what is it about psychiatry that's so gripping for you?
I think for me, it's the idea that, like no other discipline, there is a science to psychiatry, but there's also an art. And it's this idea that we can actually manage and we can promote mental well-being, because the World Health Organization says that there's no health without mental health. And just having that ability to be able to put all of these things together and look at a patient holistically, for me, is what drew me to psychiatry. And also this kind of, I am a fixer. So when something is broken, I want to be part of the solution. I do think that it is a good quality of life in terms of working hours, in terms of emergencies. You also get to kind of journey with patients in a way that, again, no other speciality does. You get to share in like the intimate details of somebody's life, and you kind of become like the keeper of secrets.
Sure.
And that for me is really the privilege of the work that we do. So, when somebody is referred, and they may be referred because they have, recurrent tummy aches and, stomach problems, and the GIT says like there's just nothing there and we can't understand this. Just being able to sit with that person and appreciate, the mind-body connection, and then be able to offer them solutions to a problem, sometimes that they were not even aware of, is a real privilege. And that for me is why I do the work that I do. Also, there is good earning potential. And I always say to the medical students and the junior doctors, AI is not going to replace us. Like the surgeons, shame, watch out. The robots are coming. The orthopods, shame, the robots are coming. With psychiatry, you won't be able to teach a robot about human emotion, and so I would say that the rest of medicine is at risk, but we'll still be.
The future of psychiatry is shining bright.
No, the future of medicine is psychiatry.
We spoke about the pros and what's appealing about psychiatry. Do you have any stories, without divulging personal details or identifiers, do you have any personal stories of things that were particularly rewarding for you, that when you reflect on your path so far, that you say, I know I'm making a difference and this feels really good because of this story or this case in particular?
I mean, sure, there's lots of those. There's lots of those stories. And I think for me, the kind of real wow is the fact that we get to do this every day, and we can't save everybody. But when you see, for example, just a week ago, I had a kid come into the clinic, and I can remember when I first saw this kid. If her mother didn't murder her, I was going to murder her. Sure. I mean, from attitude to dress to just her overall demeanor, it was just really, really rough. I mean, even her mother was at her absolute wit's end. And just by a process, I mean, she reminded me that she started seeing me when she just started high school, and she's now in matric this year. I mean, I didn't think that she would even get there.
Wow.
But just by the process of treatment, and even when she didn't want to and I didn't want to, the ability to keep going using the multidisciplinary team, because it wasn't just, a solo effort. It was, psychology input, it was social work input, it was, inputs at multiple levels. It was inputting, with her mom, with the family.
That's 5 years of quite intensive.
Yes,
treatment.
and I mean, she can't even believe it. She reminded me, just last week, she said, like, she hasn't cut in years, for example, whereas that was the standard. Every time there was a call or an email from mom, it was because she's cut, or because she's harmed herself, or she's actively suicidal, or she's gotten into some risky behavior. And I mean, for her to say, she's actually enrolled in a sport and she's going to the World Championships and she wants to do this after school. And I sat there and I thought, sure.
That's unreal, yeah.
It's unreal. It's one, but sure. It's been so worth it. But, it's also taught me a lot about myself. And that's, I think, the benefit of psychiatry, where I'm not the same person that I was when I started psychiatry, because in being able to help somebody in the way that we do, I also have to understand myself and my limitations. So it's been quite a point of personal growth, even for myself. Seeing the benefit of paying attention to my own mental health, because while I'm going to say expert in inverted commas, I'm also a patient, and I think we all are patients in some way or the other, because when we come to medical school, we don't just come with the academic part of our brains. We come with all our experiences. We come with all of our, things that have happened to us. We come from families of origins. We bring all of this, but we almost like switch off those things, and we go through medical school. And then you arrive at a place where it's like, okay, like what now? Because you're moving on and developing, but you've kind of cut off parts of yourself to kind of be present at medical school, because you don't bring all of yourself. You've got all of these things happening, but it's like you cut off from them because you just need to get this
part
done.
of professionalism is to have that objectivity and, almost, like you say, to cut away some of yourself, put it away that you can deal with it at a different time. But in your professional space, you're a certain way.
You are a certain way. But the thing about that is that as people, we are whole. How do you cut off those parts of yourself? So, and then you finish medical school and you then expected to be a fully grown adult who has to make decisions about marriage or not, whether you want kids or not, or how you want to live your life, for example.
Yes.
But we've almost had our development stifled, in a sense.
Wow.
Because we've been so caught up with the academic parts of our
that's a deep
brain.
thought.
And it's so overwhelming to go through medical school. I mean, if I think back on my training in medical school, I definitely think that it was probably around about my third year of study. Now, in retrospect, I think I definitely had depression because I lost weight. I was not sleeping. I was not eating. I had this constant anxiety. I remember I used to have this recurring dream of like my teeth falling out my mouth. And I just wasn't functioning optimally. But I can remember my dad taking me to the hospital because I'd lost weight. So that was the thing that was being focused on. I remember going to have TB tests and every last test for infective markers and the whole toot. But nobody actually asked about, like, how are you doing? And I remember there was a lot happening in my family at that time, but I had to continue, like, functioning and doing this thing. And I remember at the end of my third year, it was the first time ever I had to sup, like, anatomical pathology that year, but I realized it was a culmination and it went untreated.
Sure.
Because we're so like focused on getting this done that we forget that we're people. So I think a lot of the time we dehumanize ourselves. Like as medical professionals, we have this like narrative that we are super beings, like we're supermans, and you know, we almost robotic. But I do think that as the stresses increase, that's going to be more and more of a problem.
Yeah, I think it's a good opportunity to say that we will definitely be having a in-depth episode about mental health in an upcoming episode of the Dr. Coffee podcast. And I would like to unpack a little bit more within this episode as well, ask you some questions about the stress that we're under and how we can optimize our own behaviors and our work environment to help with that. And you can give us some further advice on managing stress. Is psychiatry more stressful than other specialties because of the nature of the problems that you're treating?
I think all specialties are stressful in their own way.
Sure, reg time in anything is difficult.
Reg time in anything is difficult. So I think that, when you are, if you talk to the surgeons, they'll tell, and I think it is, I think medicine is just stressful. I think that the system and the environment that we find ourselves in is stressful. I mean, with the fact that we have such a lack of resources, but again, because of the type of people that we are, ons maak 'n plan. If there's not enough food in the hospital, it's the doctors and the medical staff who are rallying and solving the problem. So
we saw that recently at Barrow when there was no one to serve bread and tea.
100%. So we're constantly making a plan because we are fixers by personality. So even though we are in a resource-strapped environment, we want to give 100%, which is not always possible, but we do because that's the personalities that we are.
Which leads to a fair measure of moral injury because you have the best intentions for your patients, but often you can't carry that through. And there's also outside of the hospital, there's systemic influences and social determinants of physical as well as mental health that are going to mean that as soon as you've made this patient well enough, they're just going to go into an environment where they have a high chance of becoming unwell again. Are there any things we can do to offset that moral injury, that stress, and that burnout to a certain degree that we all feel?
I mean, the one thing about burnout is that there is a systemic component to it, which you've just discussed. And so, when there's a systemic, that does then bring a sense of helplessness, to us because there's only so much that we can do. But as medical professionals, I do think, and I'm going to say that when we think about psychiatry, we think schizophrenia, right? Schizophrenia is only 1% of the population. It is not a very common condition. Yes, it might be what we see in the hospital because those are the patients that need to be admitted, right? But the larger chunk of work or the more common mental illnesses are anxiety and depression. And the current stats say that 1 in 3 South Africans will suffer with anxiety or depression, right? How do we think as medical professionals that we are exempt from that 1 in 3?
100%, yeah.
Because we're human after all. And so it's the common mental health problems that are actually the bigger problems in that regard. So taking care of ourselves and our mental well-being is going to need to become a priority if we are going to be able to sustain the work that we do. And yes, I know that, when we start talking about burnout, even for myself, I'll go, who, what, where, how, me burnt out? Absolutely not. But I can recognize burnout in everybody else except myself. Because there's such also like a stigma because of the things that we tell ourselves, in terms of if I'm burnt out, that must mean that I'm weak or, why am I burnt out and so is not burnt out. But I do think that we don't talk enough and we don't normalize, conversations around mental health enough. And I think that that's become more apparent because there's been an increase in the suicide rate. And so for me, it becomes a life and death issue. And how do we then, as individuals, start to prioritize our mental well-being?
Yes.
And a lot of the time people go, oh, but I don't have time. But actually, the way I kind of see it is we need to live in balance, okay? Our bodies have been created in an amazing way. We have a sympathetic nervous system and a parasympathetic nervous system. Your sympathetic nervous system, flight, fright,
fight.
But our parasympathetic nervous system is the calming part of the system. It's the system that helps us to numb, to calm.
To rest and digest.
To rest and digest, right?
Yes.
So it's about being mindful of where your system is,
Yes.
like on a daily basis, and what are some of the things that you can do to bring that balance, which is not going to take money or lots of time. So even at your desk, for example, if you only have 3 minutes, do a check-in. Where am I at? Because a lot of times we glory in the fact that I didn't have lunch, I was running around, I didn't even get a chance to use the toilet. I mean, I often tell like the Chem 4 students, like, you are going to know what urinary concentration, concentrated urine feels like in your internship year. But that's not okay, because that says that you are not in tune with what's happening in your body. And that's why we can't recognize when there's something wrong. It has to be obviously wrong before we realize that, I actually I may have a problem, So it's about being in tune, and how do you then begin to take care of yourself? Because if you don't take care of yourself, how are you going to take care of your patients?
Yes.
Are you going to be giving them the best care? I can remember during COVID, I heard a talk by an ethics professor, Professor Amy Sty, and she said that even the rules need to change, because our greatest resource, and I think that's what COVID taught us, our greatest resource was a human resource. If we don't look after our human resource, we're going to run into problems. So she said, instead of it being patient care first, it needs to be self-care and then patient care.
And you see that principle in terms of managing emergency situations in the ER, for example. They'll say, make sure you wear your personal protective equipment first. That is a physical embodiment of the principle you're talking about now, where you look after yourself first on the inside, regular check-ins, etc. And we'll talk about some more practical ways. But I just want to review what you said, because I think you said that 1/3 of South Africans are struggling with those big two, anxiety or depression.
Substance abuse as well.
And substance abuse as well. Okay, so anxiety, depression, substance abuse. That's 1 in 3. I would dare say that it's a lot higher amongst medical students, junior doctors, and even consultants, because of the stressful environment we find ourselves in, which is high pressure, high stakes, and because of the nature of the problems that we're dealing with every single day. The hospital is a concentration of society's problems. As you said, we tend to focus on schizophrenia, even though it's 1%, but it's because in a ward of 20 patients, most of them are schizophrenic. So in the hospital environment, you tend to think like the world's just falling apart. You're seeing all these problems. Now, having built that foundation, and you mentioned introspection, regular check-ins, what are some of your high-yield, best ways to approach our own mental health? What are some of the daily disciplines, the habits, the behaviors, the protective mechanisms we can put in place, so that this isn't something that we only start to worry about when it's bad, but something that we can put in place protective measures so that we don't get to that bad place?
So, I mean, we were chatting before the podcast, and I got involved with the Healthcare Workers Care Network, which is caring for the carers. It was during COVID, where as psychiatrists and psychologists, we wanted to, do something in our bit, and it was about supporting the mental health of healthcare workers, and including junior doctors. And it was quite interesting that when I started out and looking at the literature, my first thought was it can't be this simple.
Okay.
Are they kidding me? Right? But this whole idea that we need to live in, what is your sympathetic and your parasympathetic nervous system doing?
Yes.
So just things like, for example, staying hydrated, right? That helps to bring some balance, right? Just doing a half an hour of exercise. But I'm sure as an intern or a comm service, you're running around, that's exercise, but maybe you want to kind of do it in a more sustained way.
Yes.
I do a boxing class about 3 times a week, and there's 1 or 2 medical students who are, in the class.
Yes.
So it's like a half an hour of exercise. If it means then just waking up a half an hour earlier, for example. But even just 30 minutes of walking
Yes.
3 or 4 times a week, there's benefit to that.
We dealt with this in a previous episode, so I just want to build on what you're saying, because sometimes we can look at our watch, it says we've done 20,000 steps and think, I've exercised. But what was the nature of those 20,000 steps? It was in a stressful environment with your arms full of forms and patients' files, and you were on your way to go book something and then making a mental note of, I mustn't forget to do this. It wasn't an opportunity for you to defrag. It wasn't a focused physical activity that you were doing, which is what exercise should be. And further to what you're saying, that 30 minutes of exercise, if you take it in the context of a 24-hour day, is less than 2.5% of your day.
Yes.
So it's 2% of your day. To make that time, we all say we don't have time. You can't afford not to make time to exercise. Sorry, I interrupted you there just to build on that point.
Yes. And so, I mean, exercise is, so essentially get something and choose something that you love. Like, I hate gym. Like, I really do. But I've learned that it's a necessary evil. So I then choose something that I like. Running is a no-no, but walking I do. I love to hike, for example. So when I'm off, and I've used hiking, for example, as a way to also do some advocacy work for mental health. So we've done like crazy walks, because I realize that people pay attention when you do crazy stuff. So we've done base camp, we've done Everest Base Camp, we've done Kili, we've done... There's the South African tanker where, I mean, crazy, but we like on foot for 10 days, like nearly 300 kilometers. But that allowed us to, one, I got movement in, but also even just the build up to that was a focus on movement, exercise, getting it done. And I find that I definitely do better when I have like something to work towards. But it then shone some light on, so we used it as a tool, because people listen, as I say, and they give you money when you're doing like crazy things.
So we've mentioned self-care of hydration, and obviously sleep hygiene I think would fall into that as well.
Sleep hygiene, so just getting enough sleep, even just what you eat, that's important. So think about what you're going to eat, because junk food, it really tastes good, but then structure it so that it's not like unattainable. If you're going to have your junk food twice a week, that's your cheat. So I think we need to be more intentional about it, and then also just watch, because ways that, or maladaptive ways that you might be coping with stress, like your alcohol intake is increasing, and just simple things like just taking a minute sometimes, even if you're in the passage, to just breathe will bring balance, and it will activate your autonomic nervous system. So it might not take the stress away, but it will bring it down to a lower level, so you're building up again.
Yes.
When you get to that level again, if you just drop it so that the stress curve is not linear and escalating, it's kind of more of a manageable. So I like to think of them as micro recharge moments. So, things like breathing, but sometimes even just connecting with your fellow intern in the passage for 3 minutes, just how are you, or sending a text to your family or video call, that also will bring balance. I kind of call it the 33-30. If you have 30 seconds, 3 minutes, or if you've got 30 minutes, and you can do practical things that will just help to bring balance to your system, to kind of promote your mental well-being, because I'm really fatigued in treating mental illness. I think it's about how we're going to promote mental health, and I think it's something that we are going to be forced to prioritize, because there really is. The WHO says, I say, there's no health without mental health.
That's what I love what you said there. You said you fatigued treating mental illness. You want to prioritize building and promoting mental wellness.
Yes, because I think that's where we'll make the greatest impact, if we can start being intentional about our mental health. Because when your mental health suffers, your work suffers, then the quality of your work suffers, even the quality of your life suffers. So while you can be this hotshot consultant with, making lots of money, and you have an appalling quality of life, that's not really living. That's just making money.
Dr. Porter, I think you've said some amazing things so far. And I think one thing you've definitely done is establish a strong mind-body connection for psychiatric illness as well as mental wellness. What is the role then of spirituality, both in contributing towards mental wellness as well as contributing towards mental illness?
So, spirituality is really an important component. Before we used to say it's a biopsychosocial. Now we say it's biopsychosocial and spiritual.
Oh, really?
Okay?
Wow.
The other thing is that psychiatry, if we look at the Greek meaning of psyche, would be psyche, which is also similar in meaning to the soul.
Oh, wow.
So, there's definitely a mind, body. So we're made up of body, soul, and spirit. And when we talk about spirituality, we're not talking about any specific religion, because I think it's about the belief system of the individual.
Sure.
And we often use spirituality, within psychiatry as part of our assessment, because it does impact, in terms of assisting, where oftentimes that is a point of connection for a patient. And so we would ask them, to also manage the spiritual aspect of
Sure.
whatever's happening. Because, again, when we look at risk factors, there could be issues with regards to spirituality, when people are having crises of faith or crises or spiritual awakenings, in whatever way that you express your spirituality. So it is, and I think it's also an often ignored part of medicine and even psychiatry, and even just the cultural aspect sometimes of spirituality, where we are beginning to appreciate the impact of spirituality on the management and even treatment within psychiatry. So it's not something that we can ignore. But on the flip side of that, so I think that we should be working collaboratively. But oftentimes, the sort of downside or the difficulty comes in where there's a lot of stigma associated to psychiatry, for example, or even mental health problems. And so, I'll reference what I know in terms of, for example, and I know it's across religious groups as well, but I will reference, for example, within Christianity, oftentimes that there's a struggle in that, there's
pastors who say that you can't be depressed if you're a Christian.
You can't be depressed if you're a Christian, or...
Which is more harmful than helpful. Right?
Yes, just get over it, or there must be some sin in the camp, or, you need to pray, or you need to fast, and I always say, we body, soul, and spirit.
Yeah.
If the soul is sick, which is the realm of psychiatry, we need to do something about that. But my response often is that if somebody had a broken leg, we were not going to say, just walk it off.
Yeah. I like that, yeah.
And I'll go back again and say, if 1 in 3 South Africans suffer with the mental health problem, even if you are in any kind of religious organization, you're still part of that 1 in 3.
Well, South Africa is 80% Christian, for example, so there must be some Christians with mental health issues.
Oh, there's more than some, but that's a topic for a completely another day. So the stigma really is, particularly within, religious circles, which again, religion is not equal to spirituality, but, that is the reality. So there is a struggle where oftentimes, we are at loggerheads and fighting, where I got a note the other day that said I have a kid who really needs to be on medication, and I got a little Dear John note from the pastor that says that please note that he stopped taking his medication, because we don't believe in, the cheek of it. But anyway, that's a story for another day. But, so we should be working collaboratively. But I think we often at loggerheads, because there's such stigma, and I think when we don't know about something, we then fear what we don't know. So for me, knowledge is power. So creating awareness about, mental health and well-being for me is top priority, because what does a mental health problem look like? It looks like me and you know, whereas before it was this picture of this person sitting in the corner of the room, quivering and
in a straitjacket
for everyone's safety. And that is a very small percentage. The bigger percentage is the 1 in 3 of us.
I think it does come back down to what you were saying in the beginning. People have a misconception and a stigma about what psychiatry is, and they confuse you with all sorts of other things and forget that you are medical doctors first, with a medical degree first. You've done your internship, you've done your ComServe, you've done other things like surgery, and then chosen to do psychiatry.
Yeah, and sometimes I'll get patients who'll say, I can remember, because I did a bit of private practice as well before I came back into state employment, and I would have people call up my rooms and say, is the doctor Christian? Because I don't want medication. And so my answer would be, okay, if you had a diabetic DKA, would you take medication? If you're hypertensive, it's the same actual. If we look at the etiology, stress plays a role in hypertension and diabetes. It's the same with, for example, depression and anxiety. So why won't we take, the medication for that? I remember once somebody calling the rooms and saying, do I do exorcisms?
Oh, wow.
Because they'd heard that I was Christian, and so can I do this exorcism, because that's what their idea of psychiatry may have been. And so my reception is like, this is a medical practice. No, but can she? And so it does get quite tricky. But actually, if we look through, again, I'm looking through the Bible, because that's my point of reference. Mental illness has been there, they just didn't call it that. But anyway,
absolutely,
topic for another day.
No, Elijah was one of God's most powerful prophets, and yet he was in the cave saying, God, kill me, take me now, I don't want to do this job anymore, Anyway, so I think that's one thing you can draw from that, is that human beings have been human beings right through history. The stresses now are certainly different, which maybe is a good segue to a question about the ways the world is now. During COVID and post-COVID, do you think the world is more stressful and becoming more stressful? And what are some of the factors there?
So, we saw a exponential increase. Although, if I think about it, is it really that there was an exponential increase? I think there was, but I do think that people have become more aware with regards to their mental health, and there's more people struggling. So, and we've also started to normalize talking about mental health issues. But we definitely saw an increase, both in the general public. So the general population, we saw an increase in anxiety, depression, substance usage, post-traumatic stress. But the two special populations that we saw an exponential increase was in healthcare workers globally, and children and adolescents globally.
Sure.
So much so that the suicide rate in the 10 to 24-year-old age group has increased exponentially, that in some countries it's now the second leading cause of death, only after motor vehicle accidents. So
if I understand you correctly, it's the second leading cause of death in that population group, 10 to 24-year-olds. So you got your traumatic deaths, motor vehicle accidents, things like that. And that makes sense because of the younger population being more risky, that kind of thing. But the second killer after that is people taking their own life. Wow, that's deep.
And usually 90% of suicides, you will find an underlying mental health condition. That's not schizophrenia, because that's a very small percentage. It's untreated depression, untreated depression, anxiety, substance problems.
Wow. So you are the right person to ask about this, because we're going to dive deeper now into your further subspec and your special interest in child and family psychiatry. So what was it for you that was your eureka moment, or that was your kind of calling, Damascus Road moment into child and family psychiatry?
So I'm a bit of a runner.
Okay.
Not a physical runner, but
Okay.
like I can have a idea of what I want to do. So I did a lot of youth work as an undergrad, even through my postgrad training. I did a lot of volunteer youth work in Durban, and I realized that was where my passion was, and I really enjoyed. So it was almost the better part of a 20-year period just working with youth from quite a poverty background. But I enjoyed the work that I did, and when I then specialized, I took an interest, but it just felt like it would be too hard and too difficult to actually even think about doing children and adolescents, because it just felt like the task was bigger than I was.
Sure.
And so I then kind of took a bit of a shortcut, not a shortcut, but I got a get out of jail free card, and I got an amazing opportunity in private practice. Before that, I went to work in forensic psychiatry because it felt like it was the furthest away from, being involved with children.
And
so,
that's treating criminals and...
Yes, and, they're not my patients. I just, we do the assessments, we send them back, we make a decision, and, that's where it is.
Okay, wow.
And so I got this opportunity in private practice, and then went into private practice and stayed there for about 6 years in this big hospital in Durban. Built up quite a big private practice, but it was just work. I was very busy, and I definitely know that I got burnt out. And I always knew, though, that I wanted to give back. Like, for me, giving back and purpose is important. Like, I need to know why I'm doing what I'm doing. There has to be a purpose to it. And I kind of woke up one morning, and I was still in Durban at the time, and I just said to my husband, like, I can't do this anymore. Like, I don't want to do this anymore.
Sure.
I think that, we need to look at making some changes.
Wow.
And just to put in most people will start in state employ and then go back to private practice. I, however, ran away from the state because it does get quite difficult, so but he was also at a point in time where he was ready for a change. And so we decided that because there isn't much in terms of opportunities to subspecialize in KZN currently. So we then decided that we would consider relocating to Johannesburg. We had kids at the time, a very big decision. But again, it's back to it's not linear, and life can take you...
Go through seasons.
You go through seasons, it can take you up and down, and, what will be, and what's meant for you will come to pass. But, so I kind of take a very sort of view that, like, it's not linear. And you don't have to make these decisions. So, at the time I was nearly 40, and now kind of having to anticipate this major life change, having to uproot my kids and come then to Johannesburg. Because again, we can have then excuses, And the thing about decisions is that there'll never be a right time to make a decision. You just have to make it because, for example, if you are married, there'll never be the right time for the kids, for your marriage. Like, there'll always be something. So the time will never be right. So if you're waiting to make a decision for when the time is right, I have news that the time is never going to be right. There'll always be something.
You'll only notice that opportunity when it's gone.
When it's gone, So we then relocated to Johannesburg. And again, I'm quite hard of hearing. I then took a job in forensics, because that's what I knew. And after a year in forensics, I thought I was going to subspecialize. And again, not wanting to kind of say, okay, let me pursue what I'm passionate about. We used to have these ward rounds in forensics, and Friday after Friday after Friday, we would hear these extensive histories about all the childhood trauma and all the issues during childhood, and like childhood adversity that kind of brought this person to this place, but it's untreated, it's been undetected, it's just not okay. And after a year, I said to one of my colleagues, like, actually, I just need to stop what I'm doing and I just need to go back to the beginning, because I feel like I can make a bigger impact in the beginning. And she was a child psychiatrist, and she said, I understand, like, if that's what you want to do, then I think you must go and do it. I said, but I'm really scared, because the idea of subspecializing, because now I'm older, the brain is so much slower. But I thought, okay. And then I always say, sometimes the universe just conspires to make things happen, especially when you are ready. And so a post came up very serendipitously, and so I started the journey in child and adolescent psychiatry, which has been probably one of the more difficult things that I have had to do, in that I've got kids, and with children, you're not just managing the child, you're managing the family, you're having to manage school, you're having to sort of intervene at multiple layers. And sometimes you hear some really difficult stories, and sometimes even the problem started at the point of conception. And again, we live in a very resource-strapped system, or we work in a very resource-strapped system. The systems don't work. I mean, I think for the most part, we are in the middle of a child and adolescent mental health pandemic, and we haven't had much of a response. And so it has been quite a learning, and to be able to kind of separate, that's something that you learn. And I've had to, again, so it's very different to the general psychiatry training and then training in children and adolescents. It can be very overwhelming, but that's the point of training.
Yes.
With training, you learn how to separate.
I want to thank you at this point for giving so much of yourself to this interview, because it's been a long interview so far, but you've given us some real gold into this podcast. So I want to thank you for that. And I think we've got to start coming into land, so to speak. Yeah. So let me ask you some of the questions from the followers of the Dr. Coffee podcast on Instagram. We asked them to send us their questions. So one of the questions that's come in is from episode 24, where Professor Blumenthal said that, as forensic pathologists, they read thousands of suicide notes and they're able to see what people are going through. He said it's possibly a slightly egotistical boast that as a forensic pathologist, he reads more suicide notes than a psychiatrist. I don't know if that's true or not. Do psychiatrists see suicide notes, and in what context would that be? And then what can you derive from those suicide notes about the mindset of the people at the time they were taking their life? And how does it help you in managing your current patients?
So, we don't see as many suicide notes. So Prof is 100% correct, because by the time somebody then commits suicide, they're no longer our patients. So we would more often than not be involved in the pre-suicide. So we are not very often. It's very seldom that we're privy to those suicide
If somebody was unsuccessful, would you then see that suicide note?
Not always.
Okay.
Not always, because not everybody leaves a note either.
Yeah.
And again, when we think about suicide, it's very we have to look at it again. For children and adolescents, it may be different for adults, because the stresses are different from a developmental point of view. For example, with adolescents, they are more impulsive, so they might not leave a note, whereas with an adult, they might be a lot more intentional with regards to that. But more often than not, it is about an increase in the amount of stress and the perception that I am alone and there is no support. But a lot of the time it can be a perception. So yes, so family stuff, work stuff, even just trauma, financial stresses, those are oftentimes
what's driving people.
But even substance use.
So some of the other questions coming through are about maintaining our own mental well-being, which we've alluded to a little bit, as well as the stress, which we spoke about, the stress of being a psychiatrist, the stress of being a medical professional. Maybe as a closing thought, just to our audience of medical students and junior doctors in a South African context, what would be your closing thoughts about mental health and about stress and managing it well?
The thing about the South African health professionals, we are a resilient bunch and we are sought after the world over. I can remember being in England and with RMOs from all over the world, and if I was on duty, the consultant on call would be like, no stress, let them, because as an RMO you can only do so much, but they would allow the South African medical professionals to do more because they appreciate the quality of our training. Like, we're allowed to do things that other, even specialists in other countries, like for example, the cardiothoracic surgeon needs to put a chest drain in the UK.
And as an intern, you're doing it
here. As an intern, you're doing it here.
Sure.
So we shouldn't underestimate our training or the richness of the training that we get.
Yes.
So the South African healthcare force is a human resource. We are a resilient bunch. But I often hear the saying, like, I'm tired of being resilient, because resilience is in the face of such adversity, both environmental, individual, politically, we are going through the mostest here in South Africa. There's load shedding, the landscape of the country, and yet we still produce such quality. So the onus then, the system, we cannot control what's happening within the system and all the faults within the system. But the one thing that we can control is our own mental well-being. And I do think that there is a sort of almost a pressure, not a pressure, but we're going to need to begin to prioritize our mental health. And as junior doctors and as young doctors, you are going to be instrumental in changing that narrative that says that we're superhuman and we're Superman. And so we need to begin to change that narrative. And I keep saying, like, we got to start a revolution when it comes to mental health. We need to reframe this narrative, and we need to begin to normalize talking and connecting around. Like, when somebody says, how are you? Just normalizing saying, like, I'm struggling, because we also struggle to ask for help. Our help-seeking behavior sucks as health professionals. We are notoriously bad.
Yeah.
I can remember when the Healthcare Workers Care Network first started and we were still, finding our way. And so I was responsible for when requests came in, actually, connecting the person who requested with the help, because we used to do it manually at that point. And we'd have a request from a doctor come in, and would obviously be at a point where it was crisis point. And then when you try to look for the person, they would ghost you. And then we started feeling I started feeling like a stalker. I'd go and check, and see,
yes.
Where does this person work? Are they, so I can try to track them and say,
yes, we're here to help.
We're here to help. You reached out for quite a serious thing, and now you're just missing. But
Sure.
I just think we really, really suck when it comes to asking for help, because it's perceived as such a weakness. So I think the onus is on us is to start normalizing these conversations, so in terms of just as part of a day, finding ways to connect with colleagues and form these collegial support systems.
Yes.
Where we can, because sometimes we don't, and that's the thing, we don't always need to see a psychiatrist or a psychologist. We just need to be able to normalize, prioritize, and be able to connect. And sometimes just talking with a colleague is therapeutic enough.
Yeah.
And just somebody going I know how that feels.
It's a big ask, asking colleagues to just be lekker, hey?
Yeah, but...
No, I hear what you're saying, Doc. And listen, I really appreciate everything that you've had to say. I think we've got a lot to think about coming out of this podcast, that we need to prioritize ourselves. We need to prioritize our colleagues. There's a lot of practical take-home tips from this episode as well. I look forward to hopefully having you on a future episode about mental wellness, where we do a deep dive into what it is that we can do and what it is that we're facing as the junior doctors in South Africa. But for now, if somebody finds themselves in a difficult spot, if they find that they're in one of those situations, as you described earlier, maybe a bit of a crisis situation, what would your advice be to somebody to reach out for help? Where can they get that support?
SADC, which is the South African Depression and Anxiety Group, actually has a dedicated medical students helpline. It's a 24-hour helpline that's been sponsored by Discovery. That's how important prioritizing the mental health of medical students has become. Then we have the Healthcare Workers Care Network, which is caring for the carer. This is a fully pro bono service, and it's a completely confidential service. We also have the Junior Doctors Association of South Africa, JUDASA, and they've also done a lot of work in collaborating with SADC, collaborating with the Healthcare Workers Care Network, because we realize that as junior doctors, you are at greater risk for mental health concerns than the older doctors. And I think it's going to start, if the revolution is afoot, it's going to start with the junior doctors, because I think that as junior doctors, your mental health vocabulary may be a lot more than the older generations. But change definitely needs to come.
Awesome. That's a wonderful way to end today's episode. We'll put links to any of those resources in the show notes for this episode. So if you are facing something, if you're struggling, or you just want to reach out for some support, please fight the stigma, fight the urge to not seek that help, and access those resources through the show notes of this episode. But once again, just want to thank you so much, Dr. Alicia Porter, for your time in this interview. Thank you for giving so much of yourself and giving us a wider and deeper view of psychiatry and child and family psychiatry, and for your particular passion for the well-being of medical students and junior doctors in South Africa. Thank you. Well, that's it for this episode of the Dr. Coffee Podcast. Thank you to our special guest, Dr. Alicia Porter. I hope you enjoyed it and feel motivated, encouraged, and inspired. If you have feedback on what you thought of this episode or anything else on your mind, please get in touch. The podcast's email address is drcoffeeza@gmail.com. That's drcoffeeza with no punctuation marks. We're also on Instagram, Facebook, TikTok, and YouTube, and you can find links to these in the show notes for this episode. If you haven't listened to episode 24 of the podcast yet, do it now. And a reminder to send us your stories of medical procedures that you've performed on yourself or your loved ones for a chance to be featured on episode 26. Finally, a reminder that you can find links to everything mentioned in this episode in the show notes on whatever platform you're listening on. While you're there, please leave a rating or review of the podcast. Consider sharing this episode with fellow junior doctors and medical students in your world who you think would benefit from the content and enjoy it. Thank you so much for your support.